The evaluation of hypotension includes general physical examination and diagnostic tests. The physical examination is a traditional approach to decide the need for fluid therapy and includes examining the skin, eyes, and the extremities. Examination of the skin and eyes includes examining the mucous membranes for any dryness and to look out for sunken eyes. Examination of the extremities includes checking for abnormal skin turgor, poor capillary fill, weak pulse, and cool extremities. Diagnostic tests include complete blood count with differential thyroid-stimulating hormone, and, in a case of shock, STAT echocardiogram with inferior vena cava variability can be done along with stabilizing measures. Echocardiogram determines left ventricular ejection fraction, or LVEF, right ventricle pressure and presence or absence of pericardial effusion. If the LVEF and the right ventricular function are adequate, as in the case of distributive shock, then the inferior vena cava variability will play a role in managing fluid resuscitation. In a flat or collapsed IVC, consider a differential between hypovolemia and hemorrhage. Hypovolemia is from dehydration. For hemorrhage, check if the cause is from abnormal aortic aneurysm. A hemoglobin test must be done. Treatment is done by fluid or blood resuscitation. In distended, non-collapsing IVC with dilated LV, check for the cardiac causes. The management of hypotension includes adequate oxygen supply, fluid therapy, and administration of drugs. We shall discuss each of these in detail further. In hypotensive patients, to maintain adequate arterial oxygen saturation, administration of adequate supply of oxygen is the primary protocol. A target value of more than or equal to 94% is acceptable. Hypotension is usually asymptomatic. The most common symptoms include lightheadedness and dizziness. Other symptoms typically begin from the underlying etiology that include chest pain, shortness of breath, irregular heartbeat, headache, stiff neck, cough with sputum, diarrhea, vomiting, acute allergic reactions, fatigue, and reduced urine output associated with acute renal failure. In hypotensive patients, fluid administration is the first-line therapy, as hypovolemia is always present. Fluid therapy maintains a preload level, which is necessary to support the cardiac output. Either crystalloids, colloids, or packed red cells are given individually or in combination for this purpose. Fluid resuscitation should be started immediately before further investigations are carried out. Rapid infusion of a 500 to 1,000 milliliters bolus of normal saline or Ringer's solution should be done within 15 minutes. The fluid bolus infusion is to be repeated when the clinical response is inadequate. The table here explains the administration of drugs. Administration of drugs increase the cardiac output and vascular tone. Catecholamines are the preferred first-line agents due to their short half-life. Based on the effects on cardiac contractility and vascular tone, they can be separated into inodilator, which is inotrope plus vasodilator. Inoconstrictor is inotrope plus vasoconstrictor. Inodilators increase flow, even though they have increased vasodilating effects. Inoconstrictors increase perfusion pressure by affecting the flow with variable factors. Lifestyle modifications include the following: changes in the posture. The head of the bed can be raised by 10 to 20 degrees to decrease the pressure during the night to reduce hypovolemia. Regular rehydration is mandatory to reduce the orthostatic symptoms in some patients. The meal sizes, especially carbohydrates, must be reduced to prevent postprandial hypotension. Hypotension is the most common medical condition that occurs in the wards, emergency departments, operation theaters, and ICUs. It remains unrecognized as it is asymptomatic and becomes a concern only when the oxygen levels to the key organs decrease. They are broadly classified into 4 types, which are orthostatic hypotension, postprandial hypotension, neurally mediated, and severe hypotension linked to shock. The management includes adequate supply of oxygen, fluid therapy, blood, plasma, and platelet transfusion, and administration of drugs.